Hello, everyone. Welcome. I'm John Samet, Dean of the Colorado School of Public Health. This is a great day, but I wish we were together for this inaugural Richard Hamman lecture named in honor of our founding dean, Dick Hamman. We are still a new school in our 12th year, but today we are starting a tradition, bringing leaders to the school to inform us. In endowing this lecture, naming it after Dick was an easy choice, the founding dean and a longtime public health leader in the state. He launched the career of many of you listening in today, and his legacy for the school will be a long and lasting one. Let me tell you about the plan for today's lecture. First, I want to let you know that we are recording, also that we are streaming on Facebook Live, and there will be, of course, an opportunity for those unable to make it to listen to the recording. The plan for today is next to hear from Karen Arstad, Associate Vice Chancellor for Advancement, who will offer some comments. Then Dick Hamman is going to give us an overview of the evolution of the school, the vision for having the Colorado School of Public Health. Then we'll turn to our speaker, Dr. Alfred Sommer, Al, which I will be saying from here on out, and we'll introduce Al. And after his talk, we'll have a chance, you'll have a chance to pose questions, and I'll remind you to use the Q&A feature. I think this is a real opportunity to ask Al about the things he'll be talking about what we do about public health, where we have been, and more importantly, where we are going. So with that, I'll turn things over to Karen.
Hi. Thank you for joining today. I'm Karen Arstad, Assistant Vice Chancellor for Advancement on the medical campus. And I started working for CU shortly after the school was founded in 2008 and have seen the critical role that philanthropy has played in the life of the Colorado School of Public Health. Since its founding, more than 57 million has been donated to the school through philanthropy. That comes from 3,652 individual gifts, and we are so incredibly grateful. In just a decade, we've seen the School of Public Health has achieved widespread recognition and made remarkable strides in protecting and promoting public health across the state, the country, and the world. Our benefactors, including the leadership of the school, Dean John Samet and former Dean Richard Hamman, have been critical to this progress. So it is fitting that this lecture series celebrates the history of the school and its leadership. This Dean's Distinguished Endowed lecture series will exist in perpetuity because of philanthropy. This lecture honors the first dean of the school and represents the first endowed lecture series in the Colorado School of Public Health, allowing us to bring in leaders in public health to the school on an annual basis to share their expertise. Endowments like this bring sustainable funding for programs that support education, research, and the service mission on the annual basis. Thank you particularly to Dean Samet for establishing this lecture series through your own generous gifts. We're immensely grateful for your support and commitment for the school and your investment in its future. With that, I'll hand over to the former Dean, Dr. Hamman.
You're muted. Dick, you're muted, just so you know.
You're right, I'm muted. Sorry. Welcome, everybody. I was just saying that we have over 90 participants already, and we're looking forward to a great day. I want to thank John and his wife, Connie, very much for this endowment in my name. I appreciate very much that it's the first endowed lectureship in the school, and hopefully we can look forward to many more. They play a crucial role in enhancing the breadth and depth of what we get to learn and think about as as we continue to grow and have more and more impact. I must say that I got too much credit for starting the school. And I say this pretty regularly. I mean it deeply. I need to remind everyone we had almost 8 years of work by a large group of faculty, staff, students, various administrations and administrators, and the universities themselves to make this happen, because we are the only accredited collaborative school, as I understand it, still today. So to all of the people who made this happen at Colorado State, at University of Colorado Denver, and at University of Colorado, University of Northern Colorado, this lectureship is really for all of you that made this happen. So I also want to thank Dr. Sommers for being the inaugural speaker. Dr. Sommers is, as you probably know, and you will hear shortly, was the dean at the Hopkins School of Public Health, and I think he had a lot to do with changing the name to Bloomberg, but you'll probably hear more about that as well. Although his name's not Bloomberg. But, you know, we have an interesting linkage to Hopkins, and it's even more deep or deeper than what you can see today. We have 3 Hopkins related people. Myself, I trained in epidemiology and preventive medicine in the 70s at Hopkins in the Department of Epidemiology, which is the same department that John Sammet later became chair of, having left New Mexico for Baltimore. And Dr. Sommer, who is a professor of epidemiology. And there's another link that many people are aware of, but some of you may not be, and that is the link to Florence Sabin that Colorado and Hopkins have. Florence was the first full professor in the Department of Medicine at Johns Hopkins School of Medicine. And she completed her work there, having become the first woman to be elected to the National Academy of Medicine. She actually is the statue from Colorado in the Capitol Rotunda, where the statues of the states exist. And she came back to Colorado, where she was originally from, and had her probably 3rd or 4th career by helping rewrite the public health laws of Colorado and initiating many years ago the interest in academic public health that was just beginning to start when she was there in the, I want to say 40s. I forget exactly the year. John would remind me, but in any event, so we have a long history from Hopkins, and in fact, I'll just add that the first chairman of the Department of Biometrics was from Hopkins, along with 3 or 4 of the biostatisticians. And so Hopkins, in some sense, is in our blood. And I remember one of our senior members of the biostatistics faculty who, when he heard that Bloomberg was going to change the name of the Hopkins School and do a large endowment, he said, well, we should write him, because we have a lot of Hopkins people here too, and maybe he'd do it in Colorado as well. So Al, perhaps we could have an offline conversation about that. But in any event. So I want to say just a few words about the history of the evolution of where the school came from, in a sense. And I'll start back in the early 1980s, which is just after I'd arrived in Colorado as a young assistant professor. And there was a blue ribbon panel on the future of public health, brought together by the director of the state health department at the time. And there was a long discussion in that meeting about whether we should have a school of public health, although that was only one of many pieces that were discussed. But we decided that there really wasn't enough infrastructure available at that time to attempt the School of Public Health. And so the only recommendation was that we should study it. And things went relatively dormant in terms of full discussions about doing a School of Public Health over the next 10 or 15 years. At that time, there were two pieces in the School of Medicine that would be crucial. But one was the Department of Preventive Medicine and Comprehensive Healthcare, which was the department that I had half an appointment in. And the other was the Department of Biometrics, which I had another half of an appointment in. And those two departments were working together to do epidemiology and biostatistics primarily. But they also had a Master of Health Administration and a small faculty at the time, and they had a Master's in Preventive Medicine for physicians at the time, and a PhD in biometrics. This was again in the early 80s. Shortly after I arrived, and not because of anything I had to do with it, the Master of Health Administration moved to the business school. But we decided that we'd take the Master's in Preventive Medicine, which nobody had ever heard of as a degree, and transfer into the Master of Science in Public Health. And that happened in the late 80s. During that time in the 80s, I taught the first epidemiology graduate course in the School of Medicine, and it's the graduate school in my office with 2 students. It was actually a really good way as a junior faculty member to learn how to teach, because I wasn't going to hurt too many people at the time. Well, fast forward to the early 2000s, the 20 years or so. And during that 20-year interval, a lot, of course, happened that I'm going to skip over. But preventive medicine and the Department of Biometrics were fused into one department with 3 divisions: epidemiology and community health, biometrics, and medical computing. And over time, the MSPH program had 40 or 50 students, and there was well-established preventive medicine and occupational medicine residencies in the department. The PhD in epidemiology started under the biometrics PhD program for state political purposes and no other, and was first headed up by Jill Norris, who's now chair of epidemiology in the school. But at the same time around the state, what was interesting was that the University of Denver started an MPH program with very limited health research and other activities at DU. The University of Northern Colorado had an accredited master's in community health education. And Colorado State University began talking about starting a School of Public Health. So it seemed like a good time, sort of 1998, 99, 2000, to decide if Colorado actually needed a School of Public Health, and if so, what sort. In July of 2002, after about a year of deliberation, a committee of academics, public health professionals, business people, and health-oriented foundations unanimously agreed that a School of Public Health was needed, and it should be accredited, and it should be collaborative across CU, CSU, and UNC. That final piece, the collaborative piece, of course, was one of the more difficult ones from a developmental standpoint, but it also meant that the major health foundations in Colorado would be supportive early on for our initial work to get everything put together to form a school, because they were very, very solidly behind a collaborative effort. This committee felt that any new structure that was put together in Colorado needed to link public health training, research, and practice programs, to link the public health and medical community better than it had been in the past, to provide a broader range of entry-level, advanced, and continuing public health education to the public health workforce, and to promote research that addresses Colorado's public health issues and provide a focus and leadership for public health in the region. And of course, part of the initiative for really deciding that a school was something that needed to happen was that there was really a crisis in the public health workforce, resulting from aging, where many leaders were leaving the workforce, many people working in public health that had limited public health training, and of course, public health has still today a significant lack of financing. But who would have thought that we'd be facing, a COVID pandemic? Well, a lot of people thought about it actually in public health, but that it was going to happen eventually. But at the time, there were really only two questions. Well, where's the money come from? And the one that was on everybody's tongue was, who'll give the diploma for school public health from 3 schools? So we're now into the middle of the 2000s, and a collaborative agreement was signed by the leadership, the presidents and chancellors of all 3 institutions in August of 2007, following over 3 years of implementation work by a group of 60 or more faculty, staff, and community advocates. And that led to the official underpinning for this collaborative school. I was named the founding dean in December of 2007, and the first class of the school was established and admitted in February of 2008 for the first 2008-2009 academic year. By the time of the first self-study, which we started shortly after that, the school had about 125 core faculty, the majority at CU on the Anschutz campus, but almost 50 at Colorado State and about 10 at University of Northern Colorado. And there were an additional 80 or so faculty with secondary or affiliated appointments who supported the programs. The total degree enrollment had increased from about 160 students in 2008-9. Remember, the department had about 40, to 226 in 2009-10. The growth due primarily to the MPH program. Fast forward 10 years to last year, we had 606 total students on 3 campuses. And as of August this year, there were at least 370 matriculated students, which was up almost 100 from the same time last year. So the enrollment looks to be fairly strong this year, even in the face of the potential budget crisis that we all see. We have now been accredited twice, the last time for a full 7 years. So this growth comes as the vision of the school broadens to include more topic areas, more educational offerings and dual degrees, and more academic centers focused on collaborative excellence in research, education, and service. The vision has matured since we wrote it in 2006. We said the Colorado School of Public Health will become one of the nation's premier institutions for public health education, research, and practice by delivering programs that are based in science, proven in practice, and adapted through creativity to meet pressing population health needs. Together with the mission, this vision has provided guidance to all the expansion that has occurred and has attracted a more diverse and energized student body and faculty than existed just 10 years ago. As one index of this evolution, the Colorado School of Public Health was ranked 23rd among all schools of public health by U.S. News and World Report at its 10-year anniversary, having started, I guess, at 0. So, Dr. Sommers, as I said, I'm a Hopkins epidemiology alumni, and I know that our accomplishments are not yet at the level of saving lives a million at a time, as Hopkins does, but we didn't get a head start in 1916. So thank you very much for coming, and I hope that that gives you a little feeling for the evolution of the school over time.
Okay, thanks so much, Dick. And I will say personally, I think I'm here in part because Dick and I had a long conversation in which he verbally twisted my arm to apply for the position of dean at the school. So here we both are. So I want to turn to introduce Al Sommer. I'm delighted to had the opportunity to do so. Al's an ophthalmologist and epidemiologist, and I'm pleased that he's the inaugural Richard Hamman lecturer. Al was the first person who came to mind when I thought about a speaker for this lecture. He was my dean for most of my 14 years as chair of the Department of Epidemiology. Takes a long time to say this, of the Johns Hopkins Bloomberg School of Public Health. Now Dean Emeritus, Al has had a broad impact on academic public health, leading the growth of Hopkins to an unprecedented scope and influence, implementing the first remote MPH program, and pushing for the transformation of the then ASPH, now the ASPPH, the Association of Schools and Programs in Public Health, I think leading to a greater professionalization of our schools. While Al was dean, the School of Public Health emerged from the shadow of the School of Medicine, setting a needed example. His research has had global consequences. Al is known worldwide for the finding that vitamin A deficiency was linked to early childhood mortality, and then showing that supplementation saved the lives of children and their mothers. He was a pioneer in preventive ophthalmology and more. His contributions have been widely recognized. The Lasker Clinical Medicine Research Award, the Spirit of Helen Keller Award, the Fries Award, and too many more to mention. He's a member of both the National Academies of Science, the National Academy of Science, and the National Academy of Medicine. I think most importantly, Al is both a humanist and a person who takes action. His career might be best characterized by his relentless search for ways to advance public health, really at all levels and through all means. Follow his example. So I'm pleased to introduce my colleague and friend, Al Sommer, who's going to give a lecture entitled The Public's Health, Past, Present, and Future, ending with a question mark. So we'll see what that is about. So Al, thanks so much for being with us today. And as I guess we say now, the Zoom is yours.
All right, thanks very much. And if I don't get too confused by it all, I know Paul will take care of me. So I'd like to thank Dean Sammet for this invitation to deliver the lecture. My only regret is not being with all of you in Colorado. On the other hand, this presentation saves me the embarrassment of keeping up with John and his wife, Connie, who challenged us to climbing to 14,000 feet the first afternoon we arrived. I'm honored to deliver this inaugural Richard Hamman lecture. Professor Hamman and I both graduated from Johns Hopkins, as you've heard. We were both initiated into Delta Omega, and we were both former deans. And wonderfully, unlike many other named lectures I've given, this is not a memorial lecture, and the honoree is here to correct me. Professor Hamman did me one better. As a founding dean, I merely renamed the existing Hopkins institution from which we both graduated. In his talk, I'd like us all to think through basic public health together. There's no final grade and there are no wrong answers unless I can't figure out how to share my screen, which we will now discover. Here we go. Is that working for everyone? So the past and the present, I think we probably know, and we'll go over a little bit of that. And then the future is something for us to think about together. There we go. So this is one of my favorite quotes from that famous statistician and epidemiologist, William Farr, in 1837, so nothing is new. Medical science will advance not by opinions and assertions, but by registering facts, by applying that mighty instrument of natural science, arithmetic. And that's certainly what I and Dick Hamman and John Sammet have spent our life doing, with a lot of arithmetic. Now, I find this one of the most fascinating slides I've ever come upon. This is the population in the world from the birth of Christ through it extrapolates out to 2100, but we could just go up to today. Now you'll notice, I mean, I just think it's extraordinary when you think of it. The world was in fact flat, or at least the population was flat for roughly 1700 to 1800 years. And then suddenly we have this explosive uptake and growth in the population. So what's going on that suddenly after 1800 years, things just take off? Well, there are a lot of things, of course, the Industrial Revolution and more efficiencies in economy, but a lot of this, of course, is about public health. C.P. Snow, who if you don't know about, you ought to know about, said in 18th century French villages, the median age of marriage was older than the median age of death. So think about that for a minute. The median age of marriage was older than the median age of death. So what was going on? So I happened to be lecturing in Melbourne and took a few days off and went to Hobart. And there's a beautiful garden, which like in the English tradition, they take old centrally located cemeteries and then turn them into gardens, and they take the headstones and put them on a wall around the garden. So here's an old headstone in which 3 bodies are buried. 1852, Thomas Smith died age 53 years. But also in that same grave was George Edward William Smith, who died at 3 weeks, and Henry Edward Thomas White, who died at 11 weeks. So people were dying at a very young age. This is only a little more than 100 years ago. It's the age distribution in England and Wales. And look where everybody is dying. The vast predominance is within the under 5 age group. So in fact, what drove age of death was that roughly almost half the people died before they reached the age of 5. And that's what changed everything. And here we are less than 100 years later, and look where everybody's dying over the age of 75. So within less than 100 years, we see this enormous demographic transition, at least a good deal of which had to do with what we're interested in. So what are some of those things that were important back then? So this is the death rate for tuberculosis, the death rate, not the prevalence or incidence of tuberculosis, but the death rate in the United States. And if you look from 1900 going down to 1960, there is this dramatic reduction in deaths from tuberculosis. And that was before there was any chemotherapy whatsoever. And in fact, there are historians that have claimed that one of the reasons we never got entirely rid of tuberculosis was because with the onset of chemotherapy, people became less concerned. Well, why did it go down? Well, there are a whole bunch of reasons why it went down. One of them, people were much better nourished. And of course, nutrition has a good deal to do with immunity. People were better housed. So there was more room, more space between individuals. They weren't coughing in one another's face. People were better clothed. There were child labor laws that were enacted. All these things that are basic public health issues that came to make that happen. And this is not an anomaly with tuberculosis. Here's death rates from measles. And as you can see, it also dramatically declined from 1900 to 1960. And there was no vaccine available until 1965. So what was going on here? Again, the same thing, better nutrition, better housing, quarantine measures put into place where applicable, child labor laws and what have you. So what basic public health interventions did an enormous amount before we had the medical therapeutic interventions that we have today. As important as they are, we accomplished an enormous amount in public health before they came. All that happened. So my friend Julio Frank, I think, nicely summarized what were the major determinants of health. And he created the biologic factors, social factors, economic factors, and community factors. And we'll go through a few of those in the course of this talk. So when I started giving talks like this, everybody was first very excited about the genome, then they got very excited about the epigenome, and I had to therefore make up this slide about the envirome. That basically genes are important and epigenes are important, but we are having a global epidemic today, without anybody having changed a genomic structure in coronary artery disease and asthma and diabetes, and of course now COVID-19. All of this had to do with what we do to ourselves, what we do to the environment, what the environment does to us. It has nothing to do with our genome or our epigenome. And this is an old slide. This is Michael Marmot's original publication on the Whitehall study. And for those of you who haven't read it, it's worth going back to read, because it was a very insightful and important observation for public health. So he's British, and what he did was he studied everybody who worked in Whitehall, which is the British civil service in London. And of course, since he was English, it was very easy for them to separate people into classes. So you start with the administrative class. Those are the people who I would characterize as born to lead. They were the ones who went to Oxford and Cambridge, or maybe didn't even have to get their positions. Then you had the professional executive class. They would be people like us, the scientists, the physicians, what have you. Then you had the clerical class, and then you had the sweepers and the guards and so forth and so on. And he looked at what their mortality was over a 10-year period. And what he found was the lower the class, the higher the mortality. And it didn't matter whether it was heart disease or it was not heart disease. You had this absolutely lockstep relationship that if you were born to lead, you were a lot less likely to die than those of us in the professional classes, and a great deal less likely to die if you were in lower classes still. And this was a very, very powerful, I think, observation, and one, of course, which has spun a whole field of research. So if you just have to look at health, race, and wealth, it comes up very clearly. This is by my good friend Amartya Sen, who's just a brilliant, wonderful person, you know, is a Nobel Prize winner, economist, but he liked looking at lots of things. And as you can see, here was back in 1993 when he published this article in Scientific American, the survival rates for men over here to age 65, roughly. Not surprisingly, it was much lower in Bangladesh, a terribly poor, crowded country. But at that time, infinitely worse was Black males in Harlem. So a lot of this, of course, has to do with the environment we're living with and life's opportunities, and nothing or very little to do with genomes or modern medical health care. Now, William Henry Welch, who was the first founding dean of the Johns Hopkins School of Medicine, and then when he got tired of that, he became the first founding dean of the Johns Hopkins School of Hygiene and Public Health. It is a well-known fact that there are no social, no industrial, and no economic problems which are not related to problems of health. And I think, again, that goes with this general thesis that we're more than bugs and we're more than other issues that are around us. So this is a slide that I put together for a lecture I gave at Trinity College in Dublin a number of years ago. And it is the age-related coronary mortality, and let's just concentrate on the males since they're the ones that are worse off. And look at Hungary, huge compared to, say, France, or Switzerland, or Japan. But then there's Scotland, and there's England and Wales, and I was in Ireland. And there'd be no surprise at all, as I announced to that group that I was lecturing to that day, they put me up in a beautiful renovated room in the original oldest building at Trinity College in Dublin. And they gave me breakfast that morning, which consisted of 2 fried eggs, fried sausage, fried ham, fried tomatoes, and fried potatoes. And as I said to the audience, I was very fortunate to have been able to stagger across the campus that day and actually present this lecture. So clearly a lot of what we are is what we eat. The other fascinating thing, again, is all these other things that impact on our lives. So this is breast cancer mortality amongst women from 1940 to 1990. Now it's improved since then, given some of the new agents that we have. But look for from 1940 to 1990, even if you went back to 1900, there are essentially no change in breast cancer mortality amongst American women. And then you look at something that John Sammet has been very interested in and very impactful on for years, is female cancer mortality from lung cancer. If you went to 1900, it didn't even appear on the chart. And then you had this absolutely dramatic rise in which by 1990, more American women were dying of lung cancer, an entirely preventable disease, than were dying from breast cancer. So this just goes to show once again that the environment that we live in and the way we practice our lives has a great deal to do with our health and outcome. And of course, what had happened was in the early 1900s, women got more liberated after World War I, and then particularly after World War II. They took a lot of the positions that men had or were offered war, and they started to practice the same behavioral attitudes, and that included smoking. But one could do something about it. It's tough to do. So the namesake for the Bloomberg School, Mike Bloomberg, became mayor of New York, and he, with his new Commissioner of Health, Tom Frieden, decided to take a very aggressive stance to see if they could reduce smoking. And so it started very importantly with a huge increase in the tax rates. And then they banned smoking in public places like restaurants. And then they began a vigorous anti-tobacco TV ads. And you can see that with each one of these things is a relatively significant drop in smoking rates. Now, after Mike had this a while, there was an article in the New York Times which actually analyzed the impact over 4 years, only over 4 years, only doing policy issues in New York City. And let's see what happened. 18 to 24, a critically important age group, because that's when people start to take up smoking. And if you start smoking between 18 and 24, you're going to smoke the rest of your life. If you don't smoke between 18 and 24, maybe you won't. And look, there's a dramatic impact of roughly 24% in 2002. 4 years later, it's down to 16%. And the same is true with each of these other age groups, 25 to 44, 45 to 64. These reductions aren't quite as large, and I suspect because this younger age group included people who were just still experimenting and had not yet become confirmed smokers. Now, this is something that's very interesting, and I've done it in red because I've heard nobody comment on it except for me in this lecture. And so at 45 to 64, 23% of the people smoked in 2002. And went down to 19.2% in 2006. That's 45 to 64. What about 65 and over? 10% were smoking when this all began. 10% were smoking when it was all over. All right, well, that's fairly straightforward. These were people that were such confirmed smokers that there was absolutely no way that they were going to overcome the nicotine addiction, and they were going to keep smoking. But what's not been commented on, I think is fascinating, why are there only 10% smokers here, when in the younger age groups, there are twice as many or more than twice as many prevalence of smoking? Well, I think the obvious answer is those people died, and they died disproportionately. So there were many fewer smokers left in the population once you got over 65. A very, very powerful insight, I think. And John can correct me when this is over, but I don't remember ever seeing anything written about that. John has had a lot to do with the Surgeon General's report over the years. So this is the assessment back in 2013 of what impact that Surgeon General's report has had. 8 million premature deaths avoided, 157 million life years saved, and beneficiaries gained nearly 2 decades of life. That is impact. We don't always get that. Now, this is a fascinating series of maps that were on the CDC website back in 1991, well, a little bit later than that, as you'll see. It's changed since then. Then they were they were tracing the states that were suffering greater than 15% rates of obesity. Now you have to do greater than 30% obesity. But at the time these were first done, I thought this was fascinating. So this is 1991. In white are the states in which the prevalence of obesity is greater than 15%. This is 1993. It's 1995. That's 1998. If that doesn't look like an epidemic to you, I don't know what an epidemic looks like, except something like COVID-19, which has spread more quickly. But this was a behavioral change that spread. This wasn't an infectious disease that spread. Now, how did all this come about? Well, there are lots of theories, and you'll have read and will read lots of stories. But one of the best ones that I've heard is much of it had to do with a fellow who became the manager of a chain of movie theaters, and he basically invented the idea of supersizing. And what was that all about? Well, he basically discovered early on that movie theaters don't make money on the ticket sales. They make the money on the food that they sell you. And he came to the conclusion that the most powerful biblical injunction appeared to be gluttony, because he would try to sell you 2 boxes of popcorn, nobody would buy 2 boxes of popcorn. He'd try to sell you 2 sodas, nobody would buy 2 sodas. It just was something bad about buying 2 of something. So he came up with the idea, well, wait a minute, what happens if we sell you something that's bigger, that we make more profit from, and you only have to buy 1 of them? And that came along, supersizing. So let's do it with a Coke back a few years ago. So the real cost of a Coke was the 9 cents for a medium Coke for the syrup. And that he sold for $1.29. But he discovered that if he sold you a large Coke, he could get $1.49. That's 20 cents more. What did it cost him? Additional 3 cents in syrup. So he made a 17 cent added profit, which he wouldn't have made if he hadn't been able to sell you a large Coke, which everybody goes for. I can't believe the size of the popcorn boxes that people hold who was sitting in front of me in a movie theater a year ago, and maybe a year from now we'll be back there again. And that's held for most things, and because of the pricing issue. So this is the consumer price index going up from 82 to 2010. But look, fresh fruits and vegetables, infinitely higher rates of inflation, while carbonated drinks have a lower rate of inflation than the consumer price index. So people who do carbonated drinks know how to get you to buy carbonated drinks. So why was there increased obesity? From 1990 to 2000, just to take 1 decade, in that 1 10-year period, food consumption increased by 8%. That was 140 additional pounds of food eaten per person each year. 140 additional pounds of food eaten per person each year. So think about that the next time you load up your plate with some foods. Now things get a little confusing. Here's a 1-page letter to JAMA in 2018 that wanted to correct some of us with simple-minded statistical thinking. I can't understand it at all, but I want you to share it. Maybe one of you will explain this to me. Linear and quadratic trends overall and stratified by sex and age were examined in regression models with 2-year survey cycles modeled as an orthogonal polynomial and an adjusted models to determine if trends could be explained by other factors. Now that does nothing for me. I'm sure that does absolutely nothing for the public and isn't going to change the obesity rates in the United States. We have to get a little simpler than that. And while this may or may not yield a better curve fit than other things do, it's not going to advance our science very much. This is what really advances our understanding. I'm not going to go through all of these things, but I am going to go down to the Cheesecake Factory. Now, I don't know how many of you in the pre-COVID days went to the Cheesecake Factory. I love the Cheesecake Factory. The food is absolutely delicious. It's inexpensive. You get large portions. But of course, I'm a public health guy, so I'm not going to get cheesecake. I get a slice of carrot cake. And what Jane Brody pointed out in an article in the New York Times is one slice of carrot cake at the Cheesecake Factory has almost 1,600 calories. Now, John runs off 1,600 calories in 15 minutes every morning. But for the rest of us, to get rid of those 1,600 calories, I would have to run, not walk. I would have to run over 12 miles. That's a lot of work on my part for one slice of carrot cake. So needless to say, I've been having less carrot cake lately than I used to. But, you know, dietary guidelines have come, they've gone, they've changed. Nobody's gotten it exactly right, except perhaps that we're eating a lot more than we should. I like this quote, Swedes are succinct and science-based. They sum up nutritional guidance in this way. Most people know perfectly well what they should eat. It's no secret that vegetables are good for you and sugar isn't. That's pretty straightforward. And in fact, that's led to a whole lot of articles in which people question this ever-changing series of food guidelines put out by the Agricultural Department that don't make a lot of sense at all, and they're constantly changing, looking for better ways in order to describe it. I have not found them to be particularly helpful, but I did find this alternative perspective. The Japanese eat very little fat and suffer fewer heart attacks than Americans. Well, that's not surprising. But the Mexicans eat a lot of fat and suffer fewer heart attacks than Americans. The Chinese drink very little red wine and suffer fewer heart attacks than Americans. The Italians drink a lot of red wine and suffer fewer heart attacks than Americans. So this leads you to an epidemiologic conclusion that eat and drink what you like. Speaking English is apparently what kills you. All right, as Louis Sherwood, very much a basic biochemist, said, a lot of what we are talking about in prevention is behavioral change. I can assure you that it's much easier to do molecular biology. And that is, well, the real problem that we're facing is a lot of prevention is behavioral change. And if it's not baked into systems change, it's very difficult to do. Why? Because first you're trying to change the behavior by talking to the individual. And an individual has certain preferences that they've grown up with. The trouble is the individual isn't sitting there all by themselves. They're part of a social network with family and friends that have what they do as the norm. And they're part of larger organizations, churches, schools, workplace, and then finally what community and society as a whole does. And I would posit, and I'd be interested to hear what John Salmon has to say, that what really got us to stop smoking was not so much the individual deciding by reading the literature and on their own that they should stop smoking. It's because it became socially unacceptable, at least within our groups, to smoke. And that's what had a tremendous impact on the prevalence of smoking. Now that doesn't change everyone from smoking, and some people are doing a relative risk analysis here. I think he got the relative risk wrong, but that's always an issue. I like this cartoon from the New Yorker. This patrolman is holding a hairdryer. It says, it's amazing how people slow down when you point a hairdryer at them. It says a hairdryer looks like a radar gun. So we do respond to cues from the environment, even if it's a hairdryer, when we think it's something else. So when I think of obesity or tobacco use and how to prevent them, I think of 5 shuns. And that's not an S-H-U-N, it's a T-I-O-N. Education, legislation, litigation, regulation, and taxation. None of these are easy. Education is perhaps the easiest, but as we've seen lately, too much in the political sphere, legislation, regulation, taxation are problematic issues, though litigation is something that anybody can bring to the fore. Now, that doesn't mean that modern medical advances don't have an important public health impact. They certainly can. And this, I think, is a good example of this. So this is the incidence of invasive pneumococcal disease among children younger than 5 years in the United States. And look what's happened. Back in 1998, for reasons that we don't entirely understand, whites, Hispanic, Asian Pacific Islanders had relatively low rates that kept on getting lower and lower, whereas Black American children had very high rates of disease. And I've not yet seen a convincing article that explains that to me. But there was a huge change. As you can see, by 2002, Black American children are now having as little pneumococcal disease as are every other racial group. And the reason was the introduction of the pneumococcal conjugate vaccine, which reduced racial disparities. So that, we in public health generally think about the more difficult ways to change disparities having to do with provision of care, housing, economic disparities, and what have you. But healthcare disparities make a big difference as well. And if you have a new intervention and you can be sure that there's not a racial disparity in getting it, we can have a tremendous impact on the public's health. So I don't leave anything out of the domain of tools that are available to us. And then, of course, we have our current problem with biologic threats. And this goes back to the smallpox concerns following 9/11. It's a lecture in itself I won't get into, but this is a New Yorker cartoon where everybody was looking to get a smallpox vaccination, which would not have been a good idea at the time. And I played a small role in helping to convince the president that they should not vaccinate 10 million first responders. So COVID-19 that we're all living through now is unique in a century of public health. And our public health science professionals, institutions, and preparedness have not been up to the task. I mean, we knew this was coming, as Dick suggested earlier in his introduction. We get, every year we have seasonal flu, and as I'll get to, we've had a whole bunch of other diseases that are infectious in nature. We knew it was going to come. We should have been totally prepared. We should have had supplies that were packed up. They're going to be respiratory. And we should have had a playbook that we just took down from the shelf. Instead of doing what we're doing is making it up as we go along, and people doing not only very different things from one another, but doing things that are inappropriate. We haven't come very far. Everybody's into PPE and masks now, just as they were in 1665 when we had a plague. I have to remember to remind everyone. Now, I have to say this is an alleged quote from William Stewart. I actually tried to find the original one and I couldn't find it, but allegedly in testimony before Congress, William Stewart, who was then the Surgeon General in 1969, said it was time to close the books on infectious disease. And indeed, we had made a lot of progress against infectious disease, but I think Louis Pasteur many years earlier got it right. Gentlemen, it is the microbes who will have the last word, and indeed the microbes are having the last word. For those of you who are younger than I am, I have to tell you about how many diseases when I trained in medicine, and I did do a medical residency, were not thought to have anything to do with infection. So liver cancer was a terrible thing and most people died, and we had no idea why people developed liver cancer. I now know it's an infectious disease in many people. Hepatitis B, hepatitis C, aflatoxin, which is a toxin that's put off by a variety of fungi when they're growing usually on peanuts and other ground nuts that are kept under humid conditions. Cervical cancer, well, fortunately, most women in the United States could be caught early and treated. Lots of women in the developing world die from cervical cancer. And who knew? The human papillomavirus is responsible for almost all cervical cancer. And that now is prevented with a vaccine. I love gastric ulcers, gastritis, and then to some degree gastric cancers, because as a medical resident, I spent many a night keeping someone with a bleeding gastric ulcer alive with multiple transfusions until the surgeons could get there and operate. But seeing patients with ulcers, we first told them that they had type A personalities and sent them to the psychiatrist. When that didn't work, we cut their vagal nerves. When that didn't work, the surgeons cut out half their stomach. We now know that a lot of that disease is in fact treated with an antibiotic because it's caused by H. pylori. And then of course we've had more frequent unknown infectious agents like prions that cause Jakob-Creutzfeldt disease. So microbes are past and ever-present dangers. They are never going to be gone. And the usual suspects we think of as polio, which we've come close to eradicating, but haven't gotten those last few cases yet. And now we're having a problem with the vaccine-induced polio going wild. Measles, which we came very close to eradicating from the Northern Hemisphere. And it's now back again. That's before there were all the anti-vaccinators. And then, of course, flu. That's what we usually think about. But now we're having these pandemic diseases, which almost every one of them is a virus jumping to a human from another species, usually because we're eating that other species. So 3 of the most recent ones are all coronaviruses, SARS in 2003, MERS in 2012, and of course, COVID-19, which we now have. But it was also true in HIV, mad cow disease, H1N1 flu, Ebola, Lassa fever. These are not going away anytime soon. They're simply mutating and we're simply being exposed to them. And we ought to be writing a book which somebody sensible will take off the shelf and ensure that we all do. So we have constantly emerging infections. They're chronic and persistent threats. We need to develop and apply new tools, surveillance and containment, which we used successfully in smallpox eradication, but that was a unique disease that had a very effective vaccine, new vaccines, new therapeutics. But it's a biomedical public health challenge to academia and the biotech sector, but it's implementation challenge to the public sector, whether it's public health as a profession or whether it's the politicians who deal with that. SARS, you need to know about the new epidemics. We had the flu. This was a couple days ago. I hope many of you, if you want to keep up to date on COVID, go to the Hopkins Coronavirus Resource Center. It has a plethora of information. It shows when states shut down and then when they opened up, and then inevitably the epidemic pops right back up again. So it's got that kind of data on it. It has data for every state and every region of the world. And of course, the US has been leading, but India is coming up fast. Of course, India has many more people than the US, and India has a much more rudimentary healthcare system than we do. But we're, and the world is at almost 1 million deaths, and the US is at 6 million cases, abysmal for the wealthiest, most scientifically advanced country in the world. I show this slide. It doesn't, it was taken after the beginning of the epidemic. And the reason I show it to you is, for those of you who can remember back just a few months, the epidemic was here. It was in the Northeast. And everyone said, well, that's the Northeast. That's the way people are in the Northeast. They're going to get sick. They do those crazy things that they do there. And the hospitals in New York City were absolutely strained. They had to ration people they could treat. They had to store people who had unfortunately died from the disease in refrigerated trucks. I mean, it just was overwhelming. They got that under control because they did, to a large degree, what should be done once you know you've got an epidemic. And then all those places that sort of thought it wasn't going to happen there, whether it was the South or the Midwest, they now have been absolutely bombed with the disease. So it's like nobody can learn basic lessons about infectious disease. So our experience has been catastrophic despite our wealth and our expertise. We've had no political leadership except at some local levels, and where we've had it, it's been misleading. We've had a politicization of proven preventive measures, face masks, social distancing. I'm not telling anything you don't know. Bars, sporting events, church services, Trump rallies, all of these things spread the disease. You can go back to something unique about Americans, which people have known for years, and it's nice to sometimes try looking at it from another perspective. So this is a study done back in 2006. The proportion of humans that believe that humans developed from an earlier species of animal. Well, Sweden, France, and Japan, you know, the vast majority. You get to the United States, less than half Americans believe in Darwin, that believe that we actually evolved from lower species. So perhaps it's not surprising that certain politicians are able to manipulate the present, ever-present public health constraints and concerns. Beliefs and politics trump science and research. Just happens to be that the name and the word are the same. Now, John and I got into a bit of a discussion just a few weeks ago about where public health is going and what we may have learned from this lesson and what does that mean for the future. And that reminded me that 25 years ago, I gave the keynote address at the Public Health Service Uniformed Services Association and said a number of things I thought was going to get me into real trouble. Instead, much to my amazement, I got a standing ovation and many suggestions to write it up as an article, which I did in Public Health Reports. And one of the key things I said in that paper is public health, we might do well to think of public health not as a profession. Think of public health as a goal. It's achieved through multidisciplinary teams composed of numerous professions: physicians, nurses, lawyers, engineers, statisticians, molecular biologists, sociologists, economists, and let's not forget epidemiologists. So it's a goal, perhaps. It's not a profession. The profession maybe is an organizing the input and the contributions by all of these different spheres so that it impacts on the health of the public. Public health has to be a focus, and what I have found is we sometimes get confused by taking on just too many things rather than concentrating on the critical issue at the time. Now, this is a recent quote from a recent book of a wonderful guy, Vivek Murthy, former Surgeon General. And he's written a new book on the healing power of human connection. And in it, he says, loneliness is a public health crisis. Everything can't be a crisis. We have to focus and concentrate on what the crisis is, and then we can move on to the next one. But we're never going to solve 27,000 crises at the same time, because it loses its force when everything that's gone wrong is indeed a crisis. So your former governor of Colorado, Richard Lamb, I invited when I was dean to come and speak about health and healthcare at Hopkins. He gave a brilliant talk. I have to tell, I don't know what he's thought of politically in Colorado, but he gave a great public health talk. What brought health to mankind was sanitation, refrigeration, and screened windows. It's a brilliant sentence. It incorporates and encapsulates a good deal of what has improved the health of the public. And he got it right. Public health is about systems changes that promote better health, whether it's climate policy, equitable healthcare delivery, or early identification of emerging pathogens. The key determinants are health science, thinking, and planning. But as we are reminded every day, it depends upon political leadership and public responsiveness. It's not Norm Augustine, the former CEO of Lockheed Martin, once said at a talk I was at, it's not possible to herd chickens, we know that, but you can move their food, So incentives work. But sometimes you can get discouraged. Thanks very much.
So let's see, Al. Thank you so much. Let me just go live here. So thank you so much for that enormous and breathtaking survey of so much that drives our health. You did get it right on smoking. There was certainly norm change that made the difference. And for those of us who remember the days when the minute the seatbelt light or whatever went off and everybody lit up on airplanes, it was a different world and a different set of norms. For those of you who want to pose questions or comments, please do so and use the Q&A function. And while they're accumulating, I'm going to ask you one that is probably inevitable. You pointed to a lot of the sort of big drivers of why we're healthy or not, these upstream causes. I mean, the food industry is a great example. What do you see how do you see that schools of public health make a difference? We do research on those causes, but what do we do to actually try and influence broader ranges of policy? And I guess talk about everything that goes on in a school, from individuals to what schools themselves, positions they take or might take.
Yeah, that's a very good question, and one that you and I have, talked about for ages. And we all the deans get together, and professors and students, and something worth giving a lot of thought to. There's no question that you need to have the science to drive policy, and by policy I mean not just what governments pass, but what people do, and educating people. You got to get the facts right. If you don't get the facts right, there's just no point in doing anything. And people have gotten the facts wrong repeatedly, and we're constantly fighting, like the anti-vaccinators. But you got to have data, and data talk, and data are powerful, and you've got something to speak from, rather than this is my opinion, that's your opinion. Increasingly, I think schools of public health have become much more involved in practice. And by practice, again, I speak broadly. They're not going to run a health department. Very few, if any, Hopkins started by running a health department, actually. And it was a major part of the development of the school, and it had an impact on the community around which it lived, but it eventually had to give that up, and funding ran out. Just as schools of medicine have hospitals where people can actually learn to do things, and you can learn things from, we can set up trials out in the community, but it's not quite the same thing as actually being able to mark down every time a kid gets a cough or gets a cold or gets sick, and what's happening at the community level. They're all special studies that we do. Perhaps there's more ways that we can collaborate with our communities, or even be assigned parts of the community to be responsible for their health. I think that would lead to a dramatic improvement. And you can do that in concert with your medical school. And as you pointed out generously, the Hopkins School of Public Health now is the go-to place, not the medical school. The people who are getting ahead in the medical school have gotten degrees at the School of Public Health, so they can do randomized trials, and they can identify health policies. And then, of course, we've got the whole opportunity to influence legislation, and as you have frequently gone before Congress, write the reports. But just writing, reports sit on shelves. You've got to bring them out there. You've got to go to Congress. You've got to go to your local politicians. Our senior congressperson for many years was Barbara Mikulski. I had 3 absolutely organized meetings with Barbara Mikulski every year. We also used to get together on New Year's Eve. That was a different story entirely, but that didn't hurt having a relationship with our senior senator and having her being able to introduce legislation or work towards goals that we could demonstrate made a difference and were important.
Great. And of course, Barbara, unlike some politicians, had a very strong interest in science. And I think that was really important. I will say that here there's a new venture, a health campus in Aurora, where the Anschutz campus is located, that is, the School of Medicine is working with Salud, the School of Public Health, and now we're trying to look at other partners to gauge how having this health campus and more develop will influence community health. There's a few points, there's a lot of things flowing in, but
let me just add on one thing. I mean, bringing in, just as you've said, bringing in your local health department and their people, offering them courses, because many of the people working in health departments have no training, no formal training in public health, helping them advance by offering them coursework and what have you. And then they come to you with questions about how do we go about it. And you can develop a synergy that really schools of public health haven't done as ivory towers, and we need to do more of.
Yeah, no, we are not an ivory tower, and are fortunately, I think, and COVID-19 has really brought this out, tightly working with our health department on many things. Here's a question or comment that relates to this, and talking about everything can't be a crisis, even though we have an awful lot at the moment. But question is sort of what is missing in our field to stay focused and speak with one voice, or can we speak with one voice, I guess?
Well, I don't know that we have to speak with one voice, but I think if we're speaking about the same topic, it helps if we speak with one voice. I think we can each take on issues that are special to ourselves, but then what you want to do is you want to make a change locally. Because if you can make change locally and then use those local changes to demonstrate to other parts of the country, other parts of the world that one can in fact make a difference, then that becomes something that, becomes ordinary. I mean, not smoking now is ordinary. Nobody has to go out there and say, don't smoke. In parts of the world you still do, but that's because the governments make money out of tobacco sales. But most of the world knows it's not a good thing to smoke, and you can move on. Obesity is a difficult problem because people like to eat, and I'm not quite sure what we're going to do about that. But we just can't call everything, though, a crisis, because we have to pick and choose those things that we're really going to focus on. Now everyone's focused on COVID-19. I don't think anybody much cares about routine heart attacks at this moment, but we'll be hopefully over this in the next year and we can get back to other things. But to me, what this opportunity is something we should have done when we had SARS, which we fortunately avoided because the Canadians ramped down on it and the Chinese and people in Hong Kong and Taiwan ramped down on it, is we now we should have a playbook. We should be able to take that playbook down. There's going to be another COVID-19, in the next 10 years or 15 years. I mean, given global travel and given people's exposure to animal markets, it's going to happen again. We're not going to have to wait another 100 years for something like this. But we need to have a playbook that we're ready to put into practice and not forget after a year and a half, because that is the tradition. We had an epidemic, you get prepared, 2 years goes by, nothing happens, and all the money goes somewhere else. We have to remind people constantly, this is certainly something that's going to come back.
So sort of two, I think, interrelated questions, and relate to the influences. So one question is about, the enormous economic forces that may be damaging public health. And related to that is a question about fake news or misinformation, which you touched on, and how do we adapt? And I think they sort of go together, in terms of drivers of factors, determinants of health that are hard to contend with. So on the one hand, economic forces that may in fact generate fake news, as did the tobacco industry for a long time, or all the fake news, it seems to have so many sources these days and gives us bad information about public health. What do we do?
Yeah, I'm glad that I'm old for the social revolution and social media, because people can, it is fascinating when you think about, how do you get these fanatics? How do you get all these vaxxers together? Well, it used to be any one person who's being non-science based, they'd have to read something, and occasionally they might come upon something that's actually valid. But they only have 4 or 5 friends that they can expose their prejudices to. Now you can have 1 million friends or 2 million friends that you expose, and the more radical you are, the more friends that you have these days. So that's how we're getting, I think, it's going to be public health where it comes to changing behavior, whether you're going to be socially distancing or not, or eating more fat or not, or smoking or not. It's going to be harder and harder to control in the future. So we're going to have to find some new ways of doing it. And I can tell you that, again, everything is COVID-19 in my life, largely at present. And I was rather astonished since you get an epidemic as soon as you open anything, that COVID-19 just spreads. So I was not surprised the American Academy of Pediatrics recommended that all children go back to school, because they're lovely people, pediatricians. They love kids. They don't care about their parents. So the fact that the kids aren't probably going to get terribly ill, but might be bringing it home to the parents, that doesn't bother the American Academy of Pediatrics. At least that's the way I interpreted their formal recommendation. And then I see this headline that the National Academy of Medicine has come out with, or the National Academies of Science, Engineering, and Medicine have come out with a recommendation that all children should go back to school. That really astonished me. That was the headline in at least the New York Times and the Wall Street Journal and a variety of other places. So I actually read one of those stupid reports that you and I work too often on, you more than me. And there's nowhere in that report that says all children should go back to school. It's a, a traditional NAM report. It's, well, on the one hand is this, on the other hand is that. But the headline that came out from the National Academies' own press office was, National Academies recommends that children go back to school. So even our own institutions aren't getting it right. So I immediately emailed Harvey Feinberg, who's the highest placed person that I could think of. And he said, I didn't even, I glanced at the report, looked okay. I certainly didn't look at the headlines. So, we've got to do some way of looking at headlines and making sure the headlines, at least of the academic and the policy issues, get their headlines right.
Headlines
And then distill it down so that the average American can understand it in, one simple sentence.
So I think two questions I'm going to bring together and that relate to, again, one of your main points is that public health is about teams and multidisciplinarity. And these questions really relate to are we teaching enough in public health schools about all that we need, all the disciplines that we need to bring to public health. One question relates specifically to quality improvement science, but I think you could talk about any line of science and are we teaching enough about working together and learning from one another?
We say that all the time, but I think we probably don't. I think you've just invented a new course for Colorado to stream to the rest of us, and that is to make changes in health, to improve health. These are the instruments, and these are the people, and these are the sciences that have to work together. So if you're going to go out there, whether you're in a traditional public health department or you're a famous professor from somewhere and you really are interested in public health, then you have to be thinking about these other areas. I'm not going to do molecular biology, but I'm going to meet with molecular biologists who are working on relevant problems and see what they have to offer and then try and put these things together. But I think that would be a great course, John. I think you should keep working on that this evening.
after the other things. So actually here's it's a comment from a student who may have political connections. I think public health schools should prepare students to run for political office. Maybe
that would be super. Public health, yes, that would be terrific. Not physicians. We have a couple of ophthalmologists one in the Senate, and he's an idiot. He was an idiot ophthalmologist too. So
we know
yeah. But we did have in the House for many years from Washington. I'm blocking on the guy's name, who was a physician but very much public health oriented, and he was a great proponent of public health programs. So the more that we can get good public health people in Congress, particularly at a time when good public health people are no longer the heads of public health agencies. You look at the FDA, you look at CDC, you look at what's happening. I mean, these are our trusted institutions, and our trusted institutions have totally fallen down. Now, recently it's because of obvious direct political involvement. But before that, they were not functioning very well. The fact that CDC couldn't make a test that worked when we could have gotten one from Germany, probably cheaper, was ridiculous. And they couldn't make one that worked, and they couldn't count. I mean, it took Hopkins to start the count of how many COVID cases. It's ridiculous. That is a core function. When I was an EIS officer at CDC, if there was a smell of a virus in Wuhan, China, Alex Langmuir would have had 10 of us on an airplane within 14 picoseconds.
Sure. So we have some information flowing in. Public health in Congress, Laura Underwood, Congresswoman from Chicago, is a former public health nurse and an MPH. And the comment on the state of Washington, Jim McDermott, if that sounds like
it was Jim McDermott who I was thinking of.
So we have a few more questions in a few more minutes. So let me see what we can do. Here's a question that only you can answer. There is currently limited integration of ophthalmology in schools of public health and in public health departments. Why do you think this is the case? And what are some of the steps that could be taken to change? So
that's an interesting question. So I actually worked overseas, went from medicine into ophthalmology, and my thing became doing public health ophthalmology. So that's why I ended up being a dean of a school of public health. And there are training programs now in a number of ophthalmology residencies around the country. And I had just been contacted the other day. We're going to have a Zoom call one evening with about 24, not all senior, but all faculty members of departments of ophthalmology who want to see more of an opportunity for more of their residents to be able to get involved and trained in epidemiology and in global issues. I'll tell you a funny story about that once. While I was dean, I sat on the advisory board of the School of Medicine at Hopkins. And the then dean of the medical school was having each of the department chairs at each session, one department chair in medicine would get up and talk about their plans for the future of their clinical specialty, training, and research by their faculty. And I was sort of admittedly dozing off a bit and thinking about something else at the time. And Julie Freischlag, who was then the chair of surgery, woman chair of surgery at Hopkins, is up there going through, and this is her training program, and this is her new recruits. And then I hear her say, and as far as science is concerned, with Bloomberg across the street, I'm thinking, oh my God, Mike is across the street and I don't know about this? How can this possibly be? Well, she was referring to the Bloomberg School of Public Health, not to the man, Mike Bloomberg. And she basically had essentially all of her junior faculty get a degree in the School of Public Health. And they have been fantastic. So they have brought epidemiology, biostatistics, health policy to an academic surgical clinical center. And the situation is clearly going both ways.
I'll just comment when we introduced our new methods series in the Department of Epidemiology, and I taught the first course the first year. The leading student was a surgeon, and one who's made some very prominent contributions around organ allocation. I mean, you know what I'm talking about.
Well, we're seeing more and more of this. One of the most fantastic centers at the school right now is called the Cochlear Institute. And it got a huge gift from the people who make the cochlear implant, although its work is not on the implant. Its work is on how to prevent hearing loss, how to make less expensive and easier to get hearing aids, because now you have to go through an audiologist. You should just be able to go to Apple and get your new hearing aid. It'll be infinitely better and a lot cheaper and so forth. His home, even though he is an ENT guy and he does surgery and does cochlear implants, his home is at the School of Public Health, and that's where the Institute sits. No. And we have any number of those.
Well, this may be just examples of lost opportunities that we should be looking for and, and finding the right.
Well, we have to be welcoming, and we have to go out and invite people to come so they can see what they can gain from it.
Yeah, I think you're right. So let's see, we have, this is a question, just a couple of last ones. This one is about calorie labeling, going back to Cheesecake Factory. I remember the shocking news that one of those pieces of carrot cake was not quite as healthy as you might have thought. I guess carrots just soak up the grease. And this is just the evaluation question. Do we know if calorie labeling, and I guess you could say there's any other measure, how do we evaluate these?
Yeah, so they actually a study or more were done in New York, because that was the first place, again, under Mike Bloomberg's administration, that required calorie counts. And it didn't make a huge difference because largely people are going to eat what they're going to eat, and largely because most people, when they put up the calorie things, it's in tiny print, especially if you go into Burger King or something. But I do have to tell you, it did affect me. I remember being on an early flight, and I'm waiting, like I'm having breakfast at the airport at 6:15 in the morning. So where do you go for breakfast? You go to a little coffee stand, and I picked up the smallest thing I thought would get me through this flight. It was a small muffin. And as I was waiting online to pay for it, I turned it over and it had 1,200 calories in it, and I put it back and got whatever else the next thing was.
Yeah.
So at least for some of us that are willing to look at what the calories are in it, it'll make a difference. Yeah. Overall, it's tougher to, I think it's a start, and you got to start somewhere, and then you got to study it and see why it's not working. If it's not working because the print is too small, make the print bigger. Pass a law to make the print bigger.
And
make people check off. I want the 2,000 calorie bun. I don't want the 1,000 calorie bun.
Yeah, there you go. So the last question, this one This is, you alluded to this, this comes out on the breast cancer story. Why has earlier detection with mammography and modern chemo not reduced mortality from breast cancer? I mean, there actually has been a decline in more recent years, but
No, there has been a decline. It stopped where, before modern chemotherapy came in, and there has been a decline. It's not huge, but it's certainly impactful for many people and a terrific advance for those people who benefit from it.
yeah, I think a major question will be actually with what is going on in lung cancer now between screening and sort of new chemotherapies, targeted molecular therapies, whether we'll see an improvement in lung cancer survival.
Well, no, I got to tell you. All right, so if we got 2 minutes, I'm going to tell you one more story. So I served on a New York Academy of Medicine panel at one point, and this goes back many years. And the idea was, it was a terrific exercise because there was a historian, a medical historian, an economist. There was a whole variety of disciplines of about 8, 9 people. And after we had done all these case studies, we decided that we would have a short session at the AMA and at the annual meeting of APHA, just to see what kind of a response we would get. So we went to the meeting of the APHA, it was just an extra add-on, come on if you're free this late afternoon, early evening. And we probably got a couple hundred people. And it was the traditional public health. Yeah, that makes sense. That's interesting. And then we did it to the AMA, and we also got a couple hundred people one evening. And I probably used the smoking as an example. And a guy got up, the first hand that went up is a guy said, no, wait a minute, Al, this really isn't so important after all, because now that we know the chemical that's most responsible for lung cancer, just like a drug, we can just have you take that drug before you smoke, and therefore you won't get lung cancer from that thing, and people can smoke. And I said, well, wait a minute. All right, so you got the drug for lung cancer. So do you have the drug for emphysema and chronic bronchitis? Do you have the drug for all the chemicals that are contributing to lung cancer, or only for one of the chemicals? I mean, the response was astonishingly different. The medical mindset that will find a chemical that works on that molecule, and that is the answer to what is a simple, where just simply stop smoking would do, was to me quite astonishing. It's a different mindset whatsoever.
So, yeah, I suspect we could continue this conversation for a long, long time, and we will, and hopefully there'll be a chance to get you out to Colorado. We do have.
I have to climb to 14,000.
No, we have some 13,000-foot peaks too. So, in any case, I mean, this has been incredible, a great start for this lecture series. I want to thank you. I also want to thank everybody who worked hard on putting things together, and I think you've started a great legacy for the Hamman lectures. Thanks all for attending, and we'll look forward to coming lectures this fall, and of course next year's Hamman lecture. Again, thanks so much.
Great.
Thank
Terrific.
you.
Pleased to be with you.
Thanks. Bye all. Thank you.